So hello guys. So in the previous videos we were actually discussing about the developmental odontogenic cyst. So today we are moving on to the last topic in this odontogenic series, which is the inflammatory odontogenic cyst. Now the term inflammatory odontogenic cyst, so the term itself tells us that it has something to do with inflammation. So in all the previous cysts we have seen, we didn't know what was a triggering stimulus. But here we know that the inflammatory odontogenic cyst actually occurs as a result of some form of inflammation, either in form of a caries or a periodontal pocket, which will induce the epithelial cells to proliferate and form the cyst. Now WHO has actually recognized two cysts, so the radicular cyst and residual cyst on one hand and the inflammatory collateral cyst on the other hand is recognized by WHO as an inflammatory odontogenic cyst in its fourth edition of classification. So now the inflammatory collateral cyst can further be divided into either a paradental cyst or a buccal bifurcation cyst. So first we'll talk about radicular cyst. So now radicular cyst, which is also called as an apical periodontal cyst or a periapical cyst, is the most common odontogenic cyst that is seen to occur. Now it is exclusively seen in the periapical region of a non-vital tooth. The tooth which has become non-vital either because of caries or some kind of a trauma. So now this is the most common lesion which is encountered clinically. So now how does this cyst form? So what is the histogenesis? So 4 types of epithelium are suggested. So it can be derived from the cell rest of Malassez, which is nothing but the remnants of the Herdwick's epithelial root sheath. So it can come from the epithelial lining of a sinus tract. So when there is an abscess there, so it tries to relieve the pressure or the contents by forming a sinus tract. So maybe this tract epithelium can form a cyst. Then when in case of a maxillary cyst, so maybe the maxillary sinus lining, so when the root of the tooth opens directly into the sinus or when the destruction has gone all the way till the maxillary sinus, the sinus epithelium can give a portion for the cyst formation. Or maybe it can come from the gingival clavicular epithelium. So among all of this, the derivation from the cell rest of Malassez is accepted. So now the pathogenesis of inflammatory cyst is different from that seen in case of a developmental cyst, and it involves 3 phases. So there is a phase of cyst initiation, so how the cyst formation begins. Next is this phase of cyst formation, so now the cystic cavity will be lined by the epithelium. Now this is phase of cyst enlargement, so the cyst has to become larger and larger. So the first is the cyst initiation. So it is greatly accepted that it is derived from the proliferation of Herdwick's epithelial root sheath remnants. So a tooth which is very normal gets affected either by caries or a trauma. Now following this, since it is neglected, the pulp actually dies and the contents or the necrotic debris, the bacterial enterotoxins, everything is coming into the periapical region. So this inflammation can actually irritate and trigger the proliferation of these Herdwick's epithelial root sheath remnants, which are nothing but your cell rest of Malassez. This will start forming a granuloma. So this is the first response. So later this granuloma changes into a cyst. So the proliferation of this epithelium is going to give rise to your cyst initiation. So the epithelial proliferation in response to the bacterial enterotoxin is going to trigger the cyst formation. So the next phase is the phase of the cyst formation. So how does this cyst form? So now the cavity will become completely lined by the proliferating odontogenic epithelium. So now 2 concepts exist in regard to this thing. So the first one, what they're saying is that there is a periapical abscess and the naked or the exposed granulation tissue in this abscess triggers the proliferation of the epithelial rest by inducing this antigenic trigger. Now these epithelial cells are going to migrate align themselves around the abscess and form a properly epithelium lined cyst. Now the central area, there will be protolytic action, thereby forming a beautiful cystic cavity. This is not much accepted. Now the second criteria, what they are saying is that the central cells in the periapical granuloma will undergo degeneration. These cells will die off and give rise to a periapical cyst. This is more accepted. Now for this theorem to be accepted, there should be some evidence. So what are the evidence that supported this claim? So first they are saying that in between the epithelium there is accumulation of the fluid, that is there is intercellular accumulation of fluid which resulted in the cells being more loosely spaced, allowing for more fluid to come inside. Again, the central cells in the periapical granuloma, that is what they are called as the central exfoliating cells, they should increase alkaline phosphatase, a weak proteolytic activity as well as decreased desmosome. So this means that these cells are dying off, and since the central cells are dying off, this gives rise to a cavity within the granuloma. Again, these epithelial cells, your fibroblast and the plasma cells, actually release MMP13 which help in matrix degradation, the epithelial cell proliferation as well as the invasion of the granulation tissue. Now moving on to the last stage, which is the phase of cyst enlargement. So again, various concepts are there. So many authors believe it's because of osmosis. Now the cyst wall in radicular cyst or any inflammatory cyst, for example, is a semi-permeable membrane. So it allows only small molecules to enter inside. So now because of the inflammation and the ensuing immune response, there are lots of lytic products. So these epithelial cells as well as the inflammatory cells, they'll start a war with each other and many will die off. So these lytic products will induce the accumulation of more and more small sized molecules within the cystic cavity, thereby increasing the osmotic pressure. Next, so these bacterial endotoxins are actually multiple antigenic targets. So in response to this, plasma cells will release immunoglobulins. So they're saying that Troller actually said that this cyst may form in response to an ineffective immune surveillance and immune suppression. Next one is lack of lymphatic drainage. So studies have shown that there is no drainage of the fluid that is seen in the center of the cyst. So the plasma protein exudate, the hyaluronic acid and the products of cell breakdown, all these things contribute to the high osmotic pressure within the cyst fluid. Now again, continued epithelial proliferation. This can also further help in the expansion. So as long as the inflammatory stimuli persist, there will be epithelial proliferation. Next is a bone resorbing factor. So the surrounding bone, when it is resorbed, it just allows the cyst to just expand and go occupy that resorbed space. So this is brought about by the matrix metalloproteinases, the prostaglandins, especially E2, interleukins like 1 and 6. These are the bone resorbing factors. Now again, lipid peroxidation of the cyst wall. So this prostaglandin E2, which is produced by the plasma cells, histiocytes, endothelial cells and fibroblasts, this is going to facilitate the lipid peroxidation of the cyst wall, thereby further allowing the expansion of the cystic cavity. So now, what all are the types of radicular cyst that is seen? So the first classification will be whether it is a periapical true cyst or whether it is a periapical pocket or a base cyst. So periapical true cyst is when the epithelium is lined fully by the cystic cavity and is adjacent but it's somewhat separate. That is, it is not directly attached to the root apex. So here, even if the inflammatory, that is the necrotic pulp, is completely removed, the cyst is capable of sustaining itself because it is well enclosed from the surrounding region. So next group is the periapical pocket cyst, wherein the cyst directly opens into the root. So once the necrotic debris is removed from the pulp cavity, this is no longer sustainable and it will start regressing. So this periapical true cyst is a group of cysts which, when not enucleated and the tooth is extracted, gives rise to your residual cyst. So again, based on the position of the cyst, there are two groups. It can be seen in the periapical region, then it's a radicular cyst, and when it is derived from a lateral foramen, it gives rise to the lateral radicular cyst. So like I told you, when the tooth is extracted without enucleating the cyst, this can give rise to a residual cyst, that is, the cyst is left back in the extraction socket. So now clinical features, again similar to every other thing. Clinically, the patient will be asymptomatic because the tooth is completely dead. So again, it has no age, gender or racial predilection. But again, it is most commonly encountered in the maxillary anteriors because that is the side which is most prone for trauma. So typically asymptomatic, but occasionally the exacerbation can lead to pain or a swelling. Now, large cyst definitely causes mild pain and swelling, and small lesions are identified only on routine radiograph. Now, the tooth associated is always a non-vital tooth. Now, again, the reports of radicular cyst in primary tooth is very rare. But again, the frequency is believed to be higher than what is reported because a primary tooth is seldom, like a carious tooth in a primary or in a child is seldom taken for a radiograph. And again, when you see any periapical region, you will believe that once you extract the tooth or once the tooth falls off, it will just regress on its own. So it is neglected or not treated or not biopsy. So these are the reasons why the frequency is reported to be very less, but it's believed to be so much higher than what is actually reported. Now radiographically, so the cyst is definitely going to resemble a periapical granuloma. So all these periapical lesions, they tend to resemble each other. So it's going to be a well differentiated radiolucency seen in the apex of a non-vital tooth. So there will be a degree of resorption in the affected tooth. Now, since the tooth is non-vital, the lamina dura or the supporting alveolar bone will be lost. Now, when you're seeing a lateral radicular cyst, if it is not clinically visible non-vital, if it's not non-vital on first look, you have to always rule out a lateral periodontal cyst also. Now, in a primary tooth, the radiolucency is going to be seen between the root, and a residual cyst is going to be visible as a round or ovoid lesion seen in the alveolar ridge following with a history of extraction. So here you can see that there is two root canal treated tooth, and in relation to the apical region you can see a well-defined radiolucency. This is suggestive of a radicular cyst. Now again, see, this is a radicular cyst seen in relation to a primary tooth, wherein you can see it is a large radiolucency seen in the extending from the interradicular region. Now this is a case of a lateral radicular cyst wherein the cyst is developed from a lateral foramen. Now this is a case of a residual cyst. So the tooth has been extracted but the cyst is not enucleated. So it's still persisting there. So multiple radicular cysts are also possible. So it most commonly seen in various morphological defects like multiple dents in dente or the dentinogenesis imperfecta. So here what happens is that the morphological defect actually facilitates early pulp exposure and an early death of the pulp. So this facilitates the formation of periapical lesions. So the histopathological features are somewhat suggestive, but again not like pathognomonic. So it will be lined by stratified squamous epithelium. So the epithelium may show inflammatory cells, it may be edematous, and it is hyperplastic. Now here the epithelium actually proliferates in such a way that the connective tissue gets entrapped within, which is called as the arcading pattern, which is exclusively kept aside for describing the epithelium in a radicular cyst. Again, there may be a prosoplasia or metaplasia in the form of mucous cells or ciliated cells, and the cystic lumen may either be empty like here or it may show cellular debris. So here you can see that the epithelium is proliferating and has entrapped the connective tissue in between its proliferating strands. And the connective tissue is densely infiltrated by the inflammatory cells. So the epithelium here is non-keratinized. So here you can see a picture of mucus prosoplegia in a radicular cyst. There are few structures called Rushton body or hyaline body seen within a radicular cyst or any inflammatory condition, for example. So these are going to be arch-shaped or your hairpin-shaped structures. Now, the source of their origin, it is considered, like lot of concepts are considered. So it is believed to be derived from the secondary enamel cuticle of 𝒕𝒊𝒏, a form of keratin, a secretory product of odontogenic epithelium. It is derived from hematogenous origin from a thrombosed venae or a venule, or from the degenerating RBCs. Among all of this, derivation from odontogenic epithelium is most accepted and recognized. So in this picture, you can actually see this linear, curved, hairpin shape, boomerang shaped, like refractile structures. These are actually the hyaline body or the Rushton body. So next, another structure that is seen is the cholesterol crystals. So now these cholesterol crystals are actually seen in the connective tissue of this radicular cyst. So now when you do a cytological aspiration, it will appear as a open book. And on histopathological examination, the processing actually washes this off and it appears as empty clefts, thereby called as cholesterol clefts. So this may be derived from a disintegrating RBC or a degenerating WBC, that is from their walls, or it can be derived from the circulating plasma lipids, as with the case of atherosclerosis. So some conditions, these cholesterol clefts are recognized as foreign bodies by the body, and multinucleated giant cells are formed which elicit an immune attack on these structures. So see, this is a histopathological picture wherein you can see these cholesterol clefts. There are numerous cholesterol clefts seen in the connective tissue. Now again, in some conditions, what happens is that these cholesterol clefts try to push their way in through the epithelium. So it causes thinning and ulceration of the epithelium. They'll form a mural nodule which is finally pushed off into the cystic cavity. That is why when you aspirate, you're able to see this cholesterol clefts. Following the expectoration of these crystals into the cavity, the epithelium heals itself by proliferation. So in case of a residual cyst or in case of a quiescent epithelium, that is a radicular cyst which is persistent for a long time, the epithelium is going to be very thin, somewhat resembling that of a dentigerous cyst. So the treatment, as we know, it is either going to be root canal therapy, and when it cannot be treated, extraction is done. Once the tooth is treated, it has a very good prognosis and it very, very rarely undergoes any kind of recurrence. But again, though rare, there are reports of malignant transformation, especially from the cyst lining. So the two cells, the first one is the squamous cell carcinoma or an intraosseous mucoepidermoid carcinoma, can actually develop from this cyst. So let's move on to the final topic, which is the inflammatory collateral cyst. So two cysts come under this, that is the paradental cyst and its brother, which is the buccal bifurcation cyst. So first, let's see what is a paradental cyst. So a paradental cyst is actually seen in the lateral aspect of a vital tooth, wherein a repeated infection in the form of either a pericoronitis or a periodontal pocket occurs in case of a partially erupted mandibular molar. This triggers the proliferation of the cell rest of Malassez, thereby forming this paradental cyst. So clinically, it will appear as a swollen, either red or normal color, painful or painless lesion, which on radiograph will reveal a radiolucency on the lateral aspect of the tooth, which can mimic that of a lateral lentigerous cyst, your radicular cyst. Since the tooth is vital here, you can rule out radicular cyst very fast. It can even mimic an OKC. So next one is the buccal bifurcation cyst. So it is seen in the buccal aspect of a mandibular molar. So there might be some enamel extensions going into the bifurcation and the buccal aspect, which allows the accumulation of food by forming a buccal pocket, which undergoes further enlargement due to a persisting or a recurrent infection, as with the pericoronitis or periodontitis, which finally results in the formation of a buccal bifurcation cyst. So now radiographically, this is going to look like a radiolucent lesion involving the entire root area covering from the cervical region. It is going to extend down like with this picture. So now histopathologically, it's going to look exactly same as that of a radicular cyst. Nothing new, nothing different. You cannot differentiate it based on histopathological examination. So you need clinical correlation and its association with the vital tooth to differentiate it from a radicular cyst. So now treatment wise, it can be enucleated now only when there is a risk of recurrent infection or recurrence of the lesion. You should do extraction of the affected tooth. Now following this, you can try irrigation with saline and hydrogen peroxide because there are reports of cases with spontaneous resolution. So overall it has a good prognosis. So I hope you liked this video. So please do press the like button, comment to this video and subscribe to our channel. Have a nice day.